Hi everyone, today we're going to look at some EKGs and we're going to identify some arrhythmias, that is an atypical rhythm in the heartbeat of an individual based on how fast it's going, how slow it's going, how typically it's beating or unsynchronized it's beating. We'll even get a chance to look at what it takes to identify a heart attack. Disclaimer, not a doctor. So if you want to learn more about EKGs that are more detail oriented than this quick snapshot, please see your healthcare provider. I want to remind you that the PQRS T waves of an EKG are based on what's happening in the heart conduction system. This P wave identifies what is happening in the atria, specifically what's activated in the atria. The QRS complex is specific to the activation of the ventricles, and the T wave is based on the recovery of those ventricles. So we can see pretty typically the PQRS complex followed by the recovery stage, the T wave. So this would be a normal sinus rhythm. We see that there is a small P wave at the beginning, a QRS complex, and the T wave at the end, slightly taller, slightly more voltage than the P wave. You can also see the spacing is pretty typical. If we look at these big squares right here, this dark red square, that's going to be about a fifth of a second, 0.2 seconds. So if I count the number of big squares here, you can see it's about a quarter to a third of a second between the last T wave and the first P wave of the next heartbeat there. And you can see that each individual P wave has the same amount of space between it and the QRS wave, and the QRS wave has the same amount of space to the T wave. This would be a perfect sinus rhythm, meaning that this individual has a very strong normal heartbeat. This individual is experiencing tachycardia, which is defined as a heartbeat faster than 100 beats per minute. That is not a good thing. That is a heart that is working way too hard. If we notice that the heartbeat space between the two heartbeats, I should say, between the T wave and the P wave here, the beginning of the P wave and the end of the T wave, it is barely over maybe a fifth of or a 20th of a second here. That would experience a very fast heartbeat over and over and over again. It doesn't matter how evenly spaced they are, this individual is experiencing a heartbeat that is too fast, too frequent. We call that tachycardia. This individual is experiencing bradycardia, which is noted as less than 60 beats per minute. You can see that the spacing between the T wave and the P wave is much too long. If we count the big squares again, let's see, the beginning of this one is a little bit after there and a little bit to there. So it's like 1, 2, 3, almost 4 different big squares. That's almost 4/5 or 0.8 of a second. That is a long time between heartbeats. This individual is having their heart beat too slowly. It does not matter that this heart rhythm is consistent over the same spacing. It is too slow, too infrequent. Their heart is not working strongly enough, and so we are calling this bradycardia. And I want you to be able to relate these tachycardic events and the bradycardic events to the normal sinus rhythm up above. You can see the spacing of a normal sinus rhythm. You can even just look at the QRS complex between the two. The QRS from there to there is about 1, 2, 3, 4 big squares. Here it's only 2 big squares. That would be too fast, twice as fast as it should normally be. And from here it's 1, 2, 3, 4, 5, 6 big squares. That's 1.2 seconds. That's way too slow for a normal sinus rhythm. We can also analyze the fibrillation of the atria and the ventricles, meaning the atypical contraction and conduction of the atrium and the ventricles. So here I have an EKG of atrial fibrillation. This would be the atrium is not contracting at a normal time, place, or sequence of events. This can be seen pretty easily If we look specifically for that P wave, remember the P wave relates to the atria. So if we are looking specifically for the P wave, well, if I find the QRS wave and I don't see a normal P wave in front of it, that is typical for an atrial fibrillation. That something is going wrong with the SA node and the atria are not firing correctly. You can see this with the sawtooth pattern that we see here. You can also see that the distance between the T wave and what would be the P wave or the QRS wave in this case is not the same spacing between each heartbeat. This individual is experiencing erratic heartbeats and is not consistent for a normal 60 to 100 beats per minute. In fact, they have a tachycardic episode here versus a more normal episode here. But the hallmark, of course, are these sawtooth patterns that show us no real P wave here, no real conduction from the SA node. Meanwhile, we could have something called ventricular fibrillation, or VFib, as you've heard it in the business. This would be a completely disorganized EKG. You can see that the normal QRS wave is not really well defined, and the T wave after it is really not defined. It's really hard to see exactly where the P wave and the T waves are. We'll look specifically at this QRS wave, the QRS complex, I should say, then this T wave, then this P wave. You can see that there is a bunch going on here, and actually, that's not even one. That's a QRS complex here, then the T wave here, and there's our P wave right there with a little bit of AFib. This would be a very, very bad EKG to see. This person is not having their ventricles fire at a consistent rate, nor are they firing normally at all. You can see the voltages here are not consistent either. So this individual is experiencing sporadic ventricular fibrillation, the inconsistent heartbeat in just the ventricles, but we do see some AFib there too. I wanted to take a moment and show you exactly what a heart attack might look like on an EKG because it is interesting to say the least that a doctor could look at a EKG hours and maybe even days after a cardiac event and be able to see what exactly goes on from days before. So what we have here is the normal EKG. And if we look at the difference between these two right here, we can see that the ST portion, the distance between the S wave and the T wave, is actually elevated so that the heart did not go back to its normal depolarization at the isocardial level. We can see that the elevation causes the T wave to be very elevated. In fact, we literally call this a STEMI because it's the ST elevation myocardial infarction, meaning that this person has had a heart attack that was a complete blockage, and this heart is having trouble getting back to normal after the QRS wave, after the ventricle contraction. And so we have this event here that pops up over and over and over again because these ventricles aren't getting back to their normal position as quickly, and therefore that is an indication that there was a blockage of some kind in the coronary arteries that leads them to not be able to get back to normal. The other way we can see a heart attack is through a depression of that ST wave right here. So here's the normal ST. This ST is far depressed underneath. It never really got back to normal and went further than that. And we would call this an NSTEMI, not ST elevation myocardial infarction. We can even see this if the T wave is inverted. And so these are all three indications of some kind of a heart attack. This would be a total occlusion, a total blockage in one of the coronary arteries. But this is also not great. This would be a partial blockage or a backflow in one of the coronary arteries, meaning that yes, some blood is getting through, but not the amount that it needs to happen. And this particular thing can happen over many weeks to months, and even sometimes for a lifetime for an individual, where we'll see an abnormal EKG based on the event of a myocardial infarction. You can see that this myocardial infarction can be seen just hours after the event to still have that elevation in the ST wave here. And that will try to go back to normal and eventually even try to invert itself with the T wave. But even after weeks to months after that particular person has a heart attack, we can see that the Q wave actually depresses further than normal individuals would have. This depression is supposed to be very, very short and very, very small, whereas this baseline with this person who had a heart attack at one point is much, much more deep and even deeper than the S wave is, and that's not normal at all. Just something to think about, not necessarily going to be on any test or anything like that. Just fun to see how we can actually see a heart attack well beyond the heart attack itself. Finally, this would be a cardiac asystole, A meaning not or none. And this would be no heartbeat, nothing going on with it. This would be the classic medical drama of beep happening with no heartbeat at all. This is very easy to see, so this will not be on the test, I can promise that. That's a nutshell of all the different abnormal EKGs that we'd be able to see just from firsthand looking at it automatically. There are plenty of other arrhythmias out there. There are plenty other ways to see EKGs and very, very detail-oriented pieces of information that we could have. But these are just enough for our class. If you want to learn more, again, talk to your healthcare provider or go to medical school. I know you can do that.